Welcome everybody to today's presentation. My name is Susan Hillier. I'm the Dean for Research at UniSA in Allied Health and Human Performance. I'd like to acknowledge that I think most of us are meeting on the lands of the Gunner people today, and that we pay our respects to elders and acknowledge their ongoing and profound connection with country. So I'm really delighted to present some colleagues who have in the past or are currently somewhat related to UniSA, certainly related to cancer research. Without jumping too much forward, I'll introduce our first speaker, Professor Susan Branford. Susan is a professor in SA pathology, which is an alliance with the Centre for Cancer Biology here at UniSA. And her particular interest in is genomics and drug resistance. Her slides are now on display, and I'll leave it to you, Susan, to take over.
Okay, so thank you, Susan. I'd first like to thank the organisers for giving me the opportunity to share the work that we've been doing over many years involving patients with chronic myeloid leukemia. And this is translated directly into clinical practice. So CML is caused by a chromosome translocation that generates an oncogenic fusion. This is the BCR-ABL fusion gene, and all patients have this initiating fusion. It causes activated and abnormal cell signaling, increased cell proliferation and survival, and genetic instability that culminates in a rapidly fatal acute leukemia. And if left untreated, patients can die at a median of 3 years, as shown here in this survival curve, with less than 30% of patients surviving beyond 5 years. But a drug discovery program in the 1990s led to the successful development of drugs that target and kill BCR-ABL expressing cells. And this really has been one of the great triumphs of cancer research. So survival for patients who were treated with the first generation BCR-ABL inhibitor, which is called imatinib, was greater than 85% at 8 years. But it took 40 years of research to shift the survival curve from the time of discovery of the causal translocation back in 1960 to the first newly diagnosed patient treated with imatinib in the year 2000. And it was around that time that we started our research of CML at SA pathology, or as it was known back then, the Institute of Medical and Veterinary Science. So we monitored patients in the first international clinical trial of imatinib using an exploratory molecular assay to measure the levels of BCR-ABL mRNA transcript level in peripheral blood. Now, at that time, response to therapy required regular, which was about every 3 months, and painful bone marrow aspirates and cytogenetic analysis. So here's a plot of the optimal reduction of BCR-ABL that we see during treatment. And we found that the rate of BCR-ABL transcript decline was a powerful predictor of treatment outcome. And we identified a molecular response level that we've termed major molecular response that essentially protects patients from transformation to an acute leukemia and death if it was achieved within the first 12 to 18 months of starting therapy. So reaching this level is now a goal of therapy for all patients because it is associated now with a near normal survival. And we and others subsequently made a number of correlations between the molecular response and outcome that have influenced therapeutic decisions. We also led an international effort to standardize molecular methods across the globe to allow the consistent interpretation of individual patient response. And this necessitated the development of an international reporting scale for BCR-ABL. So in 2013, molecular analysis using peripheral blood was formally recognized in international clinical practice guidelines. And it's now the recommended monitoring strategy, and it directs therapy change when necessary in patients with evidence of drug resistance. So patients no longer need to have the painful bone marrow cytogenetic collections. And the primary endpoint of clinical trials is no longer survival. It's now the achievement of a major molecular response at 12 months after commencing therapy. And it's drug resistance and drug toxicity that has driven the ongoing development of BCR-ABL inhibitors, because up to 20% of patients either have primary or acquired drug resistance. And generally these patients don't have this level of molecular response shown here in this graph. These patients either have no BCR-ABL reduction, and this signals treatment failure, and a change of therapy is immediately mandated to avoid the risk of disease progression, and this is called primary resistance. But more frequently, patients lose their response, as indicated by a rise in BCR-ABL, and this is acquired resistance. And over the years, we've investigated the mechanisms of resistance and contributed to the understanding of the biology of CML. And a lot of this work has been done in collaboration with the pharma industry in both national and international clinical trials, and this work continues. We're currently using new technology for patients enrolled in international clinical trials of a new BCR-ABL inhibitor called asciminib, and this was recently granted priority review by the FDA. So the major known mechanism of acquired resistance is mutation within the BCR-ABL kinase domain at the drug binding site. And shown here is the BCR-ABL crystal structure in complex with imatinib in green, and the red circle represents a single point mutation. And these can occur at an amino acid that makes a direct contact with the drug and interferes with binding. Or these mutations could be scattered throughout the kinase domain, and they can alter the conformation of the protein and interfere with binding. And here's a linear representation of the BCR-ABL kinase domain, showing the many mutations that we have identified in imatinib-resistant patients. And among the most common mutations are located within a region called the phosphate binding loop, or the P loop. And we found a very strong association with patients who have mutations in this region and a very poor survival. And subsequently, it was demonstrated that some of these mutations do indeed have a greater transformation potency relative to unmutated BCR-ABL. And this was consistent with altered substrate specificity and pathway activation. So more potent BCR-ABL inhibitors were developed over the years to combat this mutation-driven resistance. But unfortunately, these are more toxic, and each inhibitor does have a different spectrum of resistant BCR-ABL mutations. So BCR-ABL kinase domain mutation analysis is now an integral component of patient management, and characterization of the mutation is critical because it can direct the appropriate therapy based on the sensitivity profile of specific mutations. But only 50% of patients with acquired resistance have one of these BCR-ABL kinase domain mutations. And we know that these mutations are not the cause of primary resistance because we don't detect them at diagnosis. So evidence has accumulated that mutation of cancer-related genes other than BCR-ABL is associated with treatment failure in CML, including primary resistance. And a recent review of the literature found 15 studies that reported mutations in patients at diagnosis in these genes. And in our own study, we performed whole exome sequencing, copy number variation, and RNA sequencing in 46 patients that we selected based on their known outcome, either very good or very poor. And we did find a significantly higher frequency of these cancer gene mutations in patients who went on to have a very poor outcome. We did the same analysis in patients who had progressed to an acute leukemia, and we found that every patient had one or more of these cancer gene mutations, and not only single nucleotide variants and small insertions, deletions, but also gene deletions and fusions. And 58% of the patients had BCR-ABL kinase domain mutations. So this data has demonstrated that both BCR-ABL dependent, that is the kinase domain mutations, and independent, that is these other mutations in other blood cancer related genes, these mechanisms frequently co-occur. So when we look to the future of monitoring for CML in clinical practice, well, for a very long time, monitoring of BCR-ABL has certainly been the focus in clinical practice because it can predict treatment outcome, identify early resistance, and direct therapy choice. But we're now directing our research towards understanding the impact of other mutations and how their analysis can be incorporated into clinical practice to improve patient outcomes. And to this end, we have formed an international CML genomics alliance a few years ago, and we've partnered with the European-based Harmony Big Data project. And this is a central repository of anonymized data of patients with various blood cancers. And our aim is to harness the wealth of genomic information that is generated in local CML research projects by building a platform to facilitate data assimilation and analysis for improved statistical power. So there is still really a lot of work to be done to improve the outcomes for all patients with chronic myeloid leukemia. So I'd just like to acknowledge the many people who have contributed to this work, including the people from the Genetics and Molecular Pathology Department here at SA Pathology, the Centre for Cancer Biology Genomics Facility, in particular the bioinformaticians, our colleagues from SAMRI, in particular Professor Tim Hughes, and our international collaborators, and of course our patients. Thank you.
Great, thank you very much, Susan. That's a really timely presentation. Susan, some of the discoveries that you talked about, is it translatable to other kinds of cancers?
I think it is. I think the reason why CML is quite a unique leukemia is because everybody has the same molecular abnormality. But certainly what we've learned in terms of monitoring patients using molecular analysis is now being used in other cancers. Acute myeloid leukemia in particular, a very common mutation found at NPM1 is now being monitored, the transcript levels. So yes, I think absolutely this is translatable.
Great, okay. Can I ask Melissa Pitman to come back on screen? Thanks, Susan. And Melissa Pitman, Dr. Melissa Pitman, recently from SA Pathology, CCB kind of collaboration, and now working at the University of Adelaide. She's heading up the drug discovery and ovarian cancer laboratory, with obviously particular interest in drug discovery in ovarian cancer. So I'm delighted to welcome Melissa. And I just need to say that that's Susan Branford. You've got a bit of a fan base out there too, that people really enjoyed your talk. Okay, over to you, Melissa.
Thank you, Susan. Really difficult talk to follow. Thank you so much for that amazing powerhouse of career in CML there, Susan. I hope to recapitulate what you've done there. Amazing. So today I just wanted to talk to you a little bit about the work that I've done recently in pursuing new therapies for ovarian cancer. And I will talk you through some of the work I've done in the drug discovery angle, but also in developing patient-derived xenografts. So as Susan Hillier just said, I recently moved from the Centre for Cancer Biology and now started my own group at the University of Adelaide, heading up the drug discovery and ovarian cancer laboratory. Okay, so ovarian cancer, there's a clear unmet clinical need for this disease. It has the highest mortality of all gynecological malignancies and sadly only has a 5-year survival rate of 46%. Most patients end up with a epithelial type ovarian cancer, so 75% of patients have high-grade serous ovarian cancer, and this can either be derived from the fallopian tube epithelium, or it can arise in the ovary itself. This generally forms a primary tumour that then leads to eventually metastasis into surrounding tissue and organs, and then can eventually escape the abdominal cavity and metastasize further. The current treatment for this disease includes surgery and then is followed up by chemotherapy. So generally this is carboplatin and paclitaxel, although there are now new targeted therapies using PARP inhibitors, such as olaparib, that are proving to be successful for patients who have BRCA mutations. However, despite these new treatments, unfortunately, because of the late stage detection of the disease, due to the fact that it often has vague symptoms, many patients are diagnosed at late stage, and so therefore metastasis is frequent, and there is a real chemotherapeutic resistance issue for ovarian cancer. And while about a third of patients will be diagnosed with fluid buildup in the abdominal cavity, or ascites, at diagnosis, when the disease recurs, it's present in nearly all patients. And so I'm interested in this aspect of the disease and how we can prevent metastasis and progression and chemotherapeutic resistance. So in collaboration with Martin Oler at the Royal Adelaide Hospital, I have been able to work with him to collaborate on gaining ascites samples from patients. And why I'm interested in ascites samples is because they hold a mixture of both the tumour cells from a high-grade serous ovarian cancer, but also they're often associated with these cancer-associated fibroblasts. And together from this published diagram here, you can see that there's often tumour tissue, but they often are co-associated with these cancer-associated fibroblasts that form these really compact spheroids. And this makes the treatment of these tumours quite difficult because they're round and supported by those cancer-associated fibroblasts. And the problem is that these tumour cells from the ascites can then reseed and form metastases in the abdominal cavity and eventually become invasive and go beyond. So these cancer-associated fibroblasts are often shedding from the lining of the abdominal cavity, this mesothelial lining. They can break off, become activated, and go and help support the growth of the tumour. So we are lucky enough to get this ascites fluid that is collected from patients who are at late stage. They're often getting these ascites taken to relieve some of the symptoms and some of their pain associated with that buildup of fluid. And these can be used to test various treatments in our laboratory or to be used to set up models. And so this is something that I've been working on for the last year, given that I got funding from the HSCGB for this project to help establish patient-derived xenografts. So what we've been able to establish from a panel of primary patient lines from these ascites is we've been able to take those ascites tumours, collect the tumour cells, and then use lentivirus to add a luciferase reporter. We then inject those into the abdominal cavity of immunocompromised mice, which then allows us to replicate late-stage disease. And then we allow this disease to establish, and we monitor this with bioluminescence imaging to check the growth of those tumours in the mice. So far, although this has been a very slow progress, and many of them have taken around 6 to 10 months to establish and then build up and reach a clinical endpoint in our studies, we have successfully established 5 patient-derived xenografts in these mice, and we're currently collecting samples that we will eventually characterise using a panel, the TSO 500 panel, in collaboration with Professor Hamish Scott. In addition to these patient-derived xenografts, we have our more workhorse models, which are the laboratory cell lines, such as KL3s and OV90s, and these take a much shorter time to establish, cause solid tumours and metastases. So these take around 1 to 2 months, and we have these models that we are currently characterising and establishing in the laboratory. But why are we interested in this, and what are we targeting? Well, we've been interested for a very long time in how the sphingolipid pathway is contributing to cancer. And a couple of years ago, we published a paper that was able to show that sphingosine kinase, which is a kinase in the sphingolipid pathway and makes a bioactive lipid sphingosine 1-phosphate, or S1P. The balance of this is dysregulated in high-grade serous ovarian cancer, leading to more sphingosine 1-phosphate being secreted from cells, working on receptors, and then leading to pro-proliferative, pro-migratory, pro-angiogenic, and pro-survival signalling. And we found that an important negative regulator of this pathway, CYP2, was actually downregulated in high-grade serous ovarian cancer, when we screened a panel of these different tumours and compared them to normal, we saw that SIB2 was down. And when we reinstated that in our tumour cells, we saw that we had a reduction in the ability to grow those tumours in vitro. The tumours migrated less and became less resistant to carboplatin chemotherapy. And so this really started our interest in ovarian cancer and cemented sphingosine kinase as a really good target for ovarian cancer. So here in our diagram, we're seeing that sphingosine kinase is a target. It's been shown to be upregulated and linked with increased poor prognosis. But also a subsequent study then showed that in the cancer-associated fibroblasts or the stromal cells, TGF-beta, which is secreted from tumour cells, can also lead to the upregulation of sphingosine kinase in those cancer-associated fibroblasts, and can lead to this activation of the fibroblasts into activated myofibroblasts, which can support migration, invasion, and fibrosis of the tumour. So for this reason, sphingosine kinase seems like a really good target, both in the tumour, but also by targeting the stroma. And so for many of you have maybe seen talks in the past of me talking about our development of sphingosine kinase inhibitors using virtual screening. But so a couple of years ago, we did identify a small molecule inhibitor called MPAL8 that targets sphingosine kinase. And we've shown that that is able to reduce tumours in lung xenograft models, but also in acute myeloid leukemia PDX models. So that's been really fantastic. And we're now looking forward to move those into some of our ovarian cancer models. In addition to that, I've been very interested in also targeting this positive regulator of sphingosine kinase, which appears to be key for taking sphingosine kinase to the plasma membrane to pump out that S1P. And so by using this two-pronged approach, I'm using drug development and drug discovery techniques and screening and validation to try and identify and prove that these SIB inhibitors are also going to be effective for treating this axis. Our work is focused on identifying and testing new treatments for high-grade serous ovarian cancer, and we've established a panel of patient-derived xenografts and cell line models that are currently being characterized for use as models of this disease. And we are targeting this SIB1 SK1 axis in high-grade serous ovarian cancer to try and hit both the tumour cells, but also to make it a less supportive environment for those tumour cells by targeting also the CAFs. And my work is really focused on the production of small molecule inhibitors of both SK1 or SIB1 that will ultimately be tested in those models. So I want to thank our wonderful collaborators. So Professor Stuart Pitson and I have been working for 13 years or so. Lorena Davies works really closely with me. Thank you so much to collaborators Martin Oler and Carmela Riccadelli, who have really been instrumental in helping us set up these PDXs. I've got other collaborators. I wanted to also thank the patients for their patient samples, because without them we would not be able to do our work. And of course, the wonderful funding sources who have helped us with this project. Thank you.
Great, thanks so much, Melissa. That's again another fantastic talk and great work on a really nasty kind of cancer. I must admit, I was squirming in my chair at your Ascites samples. Do I dare ask you how you get those from your patients? And
I'm very lucky to say that Martin handles all of that. He kind of goes and does the procedures for us, and we just get this big giant flask of the Ascites, and then we can extract the cells by spinning them out and then trying to grow those in the lab. So he does all the hard work.
Right, yeah. So I can understand why you thanked your patients for
yes,
agreeing to be recruited. But I think it's testament to people's desire to want to help further research in a pretty nasty cancer, isn't it?
Absolutely. Yeah, I think that actual procedure does give them some relief, because I think it can be quite a lot of pressure.
I see.
Yeah,
okay.
So I think that is a useful procedure, and often they are more than happy to donate, as far as I hear from Martin, from the lovely patients at the Royal Adelaide Hospital.
Okay, great. So while I was asking my silly question, any other questions from the audience? I think we're almost out of time.
No problem.
But look, thank you everybody for attending. Just to remind, this is recorded, so I know that a lot of people will listen to this after. So I'm sure I speak for Melissa and Susan in saying that they are happy to be contacted directly if there are any further questions about this fantastic work done in Adelaide, down at the in our biomedical precinct. So thanks everybody again, and I wish you a good evening. And thanks Susan. Thanks Melissa.